This is a young female with caustic injury to the esophagus and the stomach. This was Harpic. So the patient has taken Harpic 2 months back, and yes, she has got a long stricture right from below the carina to the GE junction, a long straight stricture, and also complete obstruction of the stomach. This is the endoscopy done after 2 months. So we have done a endoscopic dilatation with the help of esophageal dilatation 3 weeks back, and we had started dilatation almost 1.5 months after the ingestion. So now you can see that there are still synechiae and mucosal sloughs here. So the esophagus has undergone again a stricture despite the dilatation, and here we are doing esophageal dilatation under fluoroscopy and endoscopic guidance. So here you can see the guide wire being passed across, and this you can see the fluoroscopic guidance. So this is done under sedation. So we have multiple esophageal dilators of different sizes. So this is a very soft dilator, and we are passing the guide wire. So with the help of the guide wire, we are passing the esophageal dilator. Comes in different sizes up to 60 French. So right from 5 French to 50 French, we get this one. These are over the guide wire dilators. They have a tapered tip, and these are made up of polyvinyl. So they are very soft, and they are flexible. They don't damage much. The damage is very minimal with this. So chance of having a mucosal disruption and rupture of the esophagus or perforation is very less with this. So this is a combined fluoroscopy and endoscopy guided esophageal dilatation. So we have some 5 millimeters to 20 millimeters size dilators, right from 5 French to 60 French dilators. So here you can see we are doing this under fluoroscopic guidance. So we have both endoscopy and fluoroscopy guidance, and we are using a guide wire. So we pass the guide wire first, then we thread the dilator over this, and then gradually pass it down. And this is a radio opaque dilator. So there are markings on the esophageal dilators. So this is helps us to see at what level we are starting the dilatation, at what level the tip is. All these things we know with the help of the markings which are there on the esophageal dilators. This procedure is done on OPD basis. The patient can come in the morning fasting and get this dilatation done and go back in the evening. And this is done under sedation or a monitored anesthesia care. Here under fluoroscopy, you can see the tip, the moving tip of the dilator. So nicely the to and fro movements are there. So we are going to dilate the stricture with the to and fro movements of this esophageal dilators, and you can see the tip so nicely. Now we have upgraded this thing. This is a sequential dilatation. So we start with a small size dilator and gradually increase the size till there is resistance. So in the last sitting we had done till 15 millimeters, and the patient was able to swallow some water. So the critical diameter, once we get the critical diameter, we can stop that. So 1.2 1.5 centimeter is a fair enough lumen for the patient to have food. So but what happens is these are very dynamic strictures. They go for restricturing again and again. So the procedure has to be repeated. So see, after the dilatation, we are able to pass the endoscope. Initially we were not able to pass. So now we can pass the endoscope till the GE junction, but we are not able to enter the stomach. Here there is a lot of resistance because there is a stricture lower down there. So we are going to withdraw the scope and do the dilatation again. So we will go down and do the dilatation. So generally we do it for 3 to 4 attempts, the esophageal dilatation, and see the response. So beyond that, if the patient is persisting to have a restructuring, then we suggest the patient to go for a coloplasty, that is the esophageal coloplasty. So esophageal coloplasty is a very well established procedure for caustic strictures or benign strictures or malignant strictures. So we routinely do a esophageal coloplasty. See, here the guide wire is being passed, and again we are doing the graded dilatation, the sequential dilatation of the lower end stricture. So once we do this, we can do the endoscopy and then pass the scope into the stomach. The fluoroscopic and endoscopic guidance makes this procedure very safe. Doing a blind esophageal dilatation is very dangerous because it can increase the risk of having perforations and mucosal tears and bleeding. So this esophageal dilatation under fluoroscopic guidance is the safe way of doing, and it decreases the risk of having a perforation during the procedure, and also the chance of having perforation is less with subregular than the balloon dilatation. After the second dilatation, so we are able to pass the scope across the lower end of the esophageal stricture into the stomach, and you can see now we are going to enter the stomach, and there is lot of stasis in the fundus of the stomach. So this patient also has got gastric outlet obstruction due to complete blocking of the antrum. The antrum is completely blocked because of pyloric stenosis, and you can see the dirty fluid in the fundus of the stomach here. So this patient also has a stomach injury, the pyloric stenosis. The pylorus is completely blocked in this patient. So this patient has both esophageal injury, that is a esophageal stricture, and also gastric outlet obstruction due to the pyloric stenosis. So you can see that we are sucking out all the fluid. The stomach, the proximal stomach is fairly okay, it is distensible. So whenever you do endoscopy to assess the extent of damage, it's very important to see the distensibility of the stomach. The stomach should be distendable and there should be mucosal folds. So if the stomach is not distensible and there are no mucosal folds, it means that there is a stricture or a narrowing of the scarring of the stomach. So here we have sucked out all the fluid and there is a complete pyloric stenosis. Nothing can be passed across. So we cannot enter the duodenum in this patient because of the tight pyloric stenosis. The pylorus is completely blocked in this patient, as you can see now. So we are not able to pass the guide wire or the scope across the pylorus into the duodenum. So this patient needs a surgery, but we are waiting here to see the response. So that is the pylorus where it's completely blocked. We are not able to see the pyloric opening at all. So the antrum is strictured in this patient. So but we are trying to manage the esophageal stricture by endoscopy, because we have been successful to enter the stomach and we have given only 2 attempts now. So if we can avoid a coloplasty, we will try and avoid coloplasty in this patient. So if the patient is coming with recurrent strictures and she is not able to eat, then definitely we are going to do a coloplasty in this patient for failed endoscopic treatment. So surgery definitely has a good quality of life when compared to endoscopic dilatation. So here you can see that the pylorus is completely blocked. So surgery definitely has a better quality of life because the patient is able to eat well and it's a one-time procedure. However, long strictures of the esophagus, curved strictures, multiple strictures, or refractory strictures, these things will push the patient towards surgery. So here we are waiting in this patient. So for another 2-3 attempts we will wait. If the patient is responding well to treatment, then we'll do a antrectomy and the Billrothman anastomosis in this patient, and we can avoid a surgery, that is a coloplasty in this patient. So if the patient is not improving, then if she's having a refractory stricture, then we will do a coloplasty, that is esophageal coloplasty, and antrectomy and gastroduodenostomy, that is Billroth 1.